Welcome to the Standing Committee on Social Development. Today we're having a public briefing on health and social services transformation with the Honourable Glen Abernethy, Minister of Health and Social Services. Before we get into introducing each other, we'll open with a prayer, and I've asked Ms. Green to start. Thank you.
We meet to serve our community, to use our resources wisely and well, to represent all members of our community fairly, to make decisions that promote the common good. We recognize our responsibility to the past and the future, and the rights and needs of both individuals and community. As trusted servants, we seek blessings on our deliberations and our efforts here today. May we act wisely and well. Amen.
And I apologize, I should actually also recognize Mr. Jim Antoine, Board Chair for the NWD Health and Social Services Authority. Welcome, Mr. Antoine. At this point in time, I'll get the members to introduce themselves, starting with Mr. Bolio.
Hello, everyone. My name's Tom Bolio. I'm an MLA for Tuneda-Willowday.
Julie Green, MLA for Yellowknife Centre. Good morning.
Good morning, Michael Nedley, MLA for Dextrol.
Kevin O'Reilly, Free Mike.
Good morning, Bruce Cooper.
Sorry, it's no problem. At this point in time, on my left is Megan Welsh, our policy analyst, and on my right is Jennifer Lafferty-Smith? Frankie Smith, sorry. Frankie Smith, and Ms. Gail Bennett, our clerks of the court, Shane Thompson from the Henday, and also the chair of the Social Development Committee. At this point in time, I'll turn the floor over to Minister Abernethy, and you can introduce your staff and our special guest, and we'll proceed with our presentation, opening remarks and presentation. Thank you.
Thank you, Mr. Chair, and I'm pleased to be here to provide a bit of an update on system transformation. I do have a couple individuals with me today. First off, on my right is Mr. Jim Antoine, who is the Board Chair of the Northwest Territories Health and Social Services Authority. I also have on my left Mr. Bruce Cooper, who is the Deputy Minister of Health and Social Services. Twice on my right is Ms. Sue Cullen, who is the Chief Executive Officer of the Northwest Territories Health and Social Services Authority. And behind us I have Ms. Kate Sills, who is the Senior Advisor to the Deputy Minister, and Ms. Susan Laramie, who is my Ministerial Special Advisor. Mr. Chair, on August 1st, 2016, the amendments to the Hospital Insurance and Health and Social Services Administration Act came into force. This was the beginning of the transformation of the health and social services system so that it will formally work as one system. Work to get that point was completed in consultation with stakeholders and the public, and many members of the Legislative Assembly have been involved in the process and supported this work as it advanced. With one system approach, we have many new opportunities to improve care and services while working towards a sustainable health and social services system that will serve NWT residents now as well as into the future. There is huge potential for innovation and change for the better, and today you'll hear about some of the ways that the NTHSSA has been working towards the goals as set out by this Assembly and our system strategic plan. In the end, all of this change is about providing better care for patients and clients in our system. However, I think it's fair to say it's certainly not without its challenges. We are a little over a year and a half into the implementation of the new authority. We know from experience from our other jurisdictions that the path to fully realizing the benefits of an integrated system takes anywhere from 5 to 7 years from start till finish. And in fact, systems continue to evolve long beyond that. We are on the right path, but we acknowledge that there is significant work to do to realize the full potential of the system transformation and our vision of the best health, best care for a better future. Mr. Chairman, I'd like to thank the members of the Standing Committee for all of their time and interest in transformation of our health and social service system. That's basically my opening comments. I'd like to turn the floor over to Jim, Bruce, and Sue for their comments. I believe we're going to start off with Bruce, and then Jim, and then Sue.
Thank you, Minister Abernethy. Mr. Cooper.
Thank you, Mr. Chair. Good morning, everybody. So this has certainly been a shared journey as a system where there's been strong leadership from the department and an excellent working relationship between the NTHSSA, Hay River, and Cleacho. So this morning, we are actually taking a shared approach to the presentation. So my piece, I want to just speak a little bit about setting the stage in terms of some of the background. So if we could move to slide number 3, actually number 4, please. So you'll recall the reason for the change in terms of moving towards a one-system model with the establishment of the authority, and it was about improving quality, improving efficiency and effectiveness of the delivery. And you know, you've heard us talk through the business planning process as a department about the challenges facing our health and social services system here in the Northwest Territories in terms of our high per capita costs, significant chronic disease profile, and there's a cluster of issues that we are much better positioned to be able to respond to as a cohesive and coming together system than we would as a series of independent authorities. This was also about improving access by reducing barriers that people were experiencing to access, standardizing approaches to management of care. And really, I know that as part of the inspiration, there were stories that the department heard and that those involved in patient care heard about patients that were not being properly cared for, who were having far too many touch points with a system that was not coordinating care properly, where an elder may have to ride in a taxi for 300 kilometers to get an x-ray, where you have a TB patient that had to see 13 people in 3 authorities before treatment started. So these are all just examples of some of what happens when you have a diffracted, non-coordinated system, and that's certainly, there was a recognition that we needed to transform in order to be able to have a one-system response and improving efficiency, well, achieving our outcome of best care, best health, and better future. So, so early on in this process, there was a mantra that we must transition before we transform, and in that transition and transformation, we must be grounded in principles. And so the principles that have guided this work are here on this slide 4, and I think they are fairly self-evident, so I won't read them. I think the important point here this was about creating a more client-centered service that respected diversity and cultures and provided better care for patients. So with that, I'll pass the mic over to Mr. Antoine.
Okay, Mr. Antoine. Thank you, Bruce.
Thank you, Mr. Chairman, and good morning, everybody. I'm really pleased to be here. I flew in from Simpson this morning and on a cold Twin Otter, and when we were ready to get on the plane, they said the plane had a flat tire. So they just had to put air in it, so we're okay. We made it here. So I'm still flying out over here. So I got, I have, oh, okay, sorry.
That's right.
So I got a written presentation here. Yeah, we are in a period of transition, like the minister was saying, and also the deputy minister. About August, two August ago, about 18 months ago, we started this transition. And we are not there yet. We still got a long ways to go, I feel. And our leadership council and the regional wellness councils have been working hard this year to engage with the public in building capacity. I have personally attended most of the regional wellness council meetings, and just to get an understanding of how things are going in the regions, and I could tell you that they're all working hard. We still, again, have to say that we still have a long ways to go in that capacity building. This work has not been without its challenges. We have worked hard to continue to build capacity with members of the Leadership Council and the Regional Wellness Council as well. This has included the steep learning curve for council members to understand a complex health and social services system, and many of these people are community advocates but not healthcare experts. And their voices are important because they are types of people regularly served by the system. We're also beginning to understand the big challenges we face in transforming our system and ensuring it is sustainable. Our financial reality includes a large deficit that we inherited. And as we come to better understand how we address this, we will need to help this committee and members of the Legislative Assembly. Just as the Assembly supported the concept and process of system transformation, we will need support as we make tough decisions going forward about how we operate to make sure we can afford to provide the care and service our people expect and deserve. On the Leadership Council, which is the territorial council, the composition of this council allows for building of working relationships between all three authorities. It allows the governance body responsible for providing direction to the authority and to also understand issues from a patient, client, family, and community lenses through the participation of the Regional Wellness Council chairs as members of the council. On the Regional Wellness Council, the Regional Wellness Councils are regionally and locally focused. Membership is gathered through an open nomination process, and the Minister of Health and Social Services appoints councils so that they are representative of the diverse people and culture of each region of the territory. These councils are working hard to meet locally and understand issues. They have traveled to many communities within their respective regions and held regular open public meetings and gather feedback and input from members of the public about the care and services the authority is delivering. This year, Regional Wellness Councils set a list of priorities that were used in the budget-making process for the Northwest Territories Health and Social Service Authority, and they continue to provide valuable input and feedback to the system. As we go forward, I expect these councils to continue establishing themselves regionally and becoming an essential part of the system improvement and public engagement efforts of the authority. That's my presentation, opening comments, and pass it on to Sue Cullen,
Thank
the
you.
Chief Executive Officer. Mr. Chair.
Thank you, Mr. Antoine. Ms. Collins?
Thank you,
And what
Mr.
slide
Chair.
are we on, if we can just,
We're on slide 6.
okay, thank you.
So I'm going to take us through the next 6 slides. So our legacy health and social services system was built or established with 8 separate health and social services authorities with 8 separate governance structures and organizational structures. And this siloed structure actually created barriers for our patients and our clients. So one of the key drivers for advancing change is the focus on improving care and services for our patients and clients. In our new structure, we have 3 health and social services authorities, the NTHC, Hay River Health and Social Services Authority, and the Cleachon Community Services Agency. The governance structure for the NTHC is comprised of a board chair, Mr. Jim Antoine, and membership from 6 regional wellness council chairs, one of which is the public administrator of HRH SSA, the board chair of the Cleachon Community Services Agency, and the Deputy Minister of Health and Social Services is an ex officio non-voting member. Hay River and Cleachon have their own independent governance structures, but are linked directly into the NTHC to support a one-system approach. We work very closely with the 3 authorities and between the 3 authorities to have and achieve that one-system approach. Our Leadership Council members are Ethel Jean Gruben from the Beaufort Delta region, Jean Adolphus from the Satu, Ruby Simba from Dutcho, Elizabeth Baskai from Yellowknife region, Patricia Schaefer from Fort Smith, Mike Mahar from Hay River Health and Social Services Authority, Ted Blondin, Cleachon Community Services Agency, and Bruce Cooper, our Deputy Minister. On slide 7, we're talking about the establishment of the NTHC. So on August the 1st, some 18 months ago, Bill 44, an act to amend the Hospital Insurance and Health and Social Services Administration Act, came into force, and that allowed us to start working as one system. So it allowed the 5 authorities, Beaufort Delta, Sawtoo, Decho, Fort Smith, Yellowknife, and Stanton Territorial Hospital to actually function under the operating entity of the NTHC. On slide 8, in June 2016, just prior to the NTHC being established, a presentation to Standing Committee took place, and the presentation focused on 3 areas: financial, innovation in care, and services and patient-client care. And so I'm really pleased to be here today to provide an update on these 3 areas, and also to talk about some other achievements we've made, some of our challenges in our first 18 months, and areas where we need to improve. Our transition continues as a process. It will certainly take time. As our minister has indicated, we envision that it'll likely take us 5 to 7 years to realize the outcomes that we want to see toward a better future. So we see transforming our health and social services system is a process and not an event. On slide 9, our approach to system transformation was and is unique in that the legislation was enacted to enable us to operate as a single authority, and then we began the work of transforming our structure and establishing our organizational design. So we're still continuing to build 18 months in. We have built a structure with regional operations providing day-to-day services and program delivery, and territorial operations teams that will lead quality improvement by providing capacity for quality improvement with that territorial lens. One of the areas that we knew with these 8 separate siloed health and social services authorities is that we weren't actually sharing information. And so now we have the ability within the 6 regions in the NTHC to actually really look at how we can improve and enhance care. Our leadership approach includes establishing a territorial operations team. So we have an executive director of clinical integration, and that individual leads quality improvement from both health and social services perspectives. An executive director of corporate and support services who is taking the lead on quality improvement around information and health technology, medical travel, and communications. We have a territorial medical director that is leading the establishment of a territorial medical staff and a chief medical information officer role. We also have regional operations. Our regional operation teams are our chief operating officers, including Stanton, are also building teams that are aligned with the quality structures of the NTHC. Both territorial and regional teams are building teams with the fundamental purpose of improving and enhancing quality care and services within our system. Our staffing decisions have been focused on maintaining regional footprints and hiring many of our new leaders from within our system and ensuring we have the right people in the right positions. This transformation approach was done on purpose. We want to build the system from within, with the guidance and input of those who know it best, the people already working in it, while continuing to deliver care and services, so needing to have core stability throughout this time of change. We recognize that we have somewhat limited our capacity for change in our first year and a half because many of the people who are being put in place to improve quality are also helping to build the structures and manage the change and assist in the structural design of our organization. We want to look at how we can improve our health and social services system with very strategic intent, not just off the side of the desk. So we have made quality our strategy. This means that everything we do, we want to learn from and improve. It has certainly taken time to gather the frontline intelligence to ensure that we make decisions that work for everyone in the system. While we have put an organizational design in place, improving quality and operational efficiencies is going to take time. On slide 10, talking a bit about the financial pressures that we've raised earlier. Completing amalgamating budgets has been difficult. This has been a difficult and time-consuming work. With the creation of the NTHC, we inherited a number of legacy financial systems that don't correlate well or work together. We inherited 3 different financial systems across the 6 previous health and social services authorities, and even the financial systems that were the same were used differently. We faced challenges with ensuring financial coding is consistent. One region may be coding a specific cost to a different account than another, which has created challenges with making comparisons and certainly doing our budget. These seem like small challenges, but they've made understanding the bigger financial picture more challenging than we thought. In our first year of operations, we've worked very hard with the Auditor General of Canada to produce our first consolidated budget. The positive impact to working as an NTHC is that a broader financial picture is helping us to better understand and analyze system-wide cost pressures. Although this work has been difficult and we have not fixed the problem of disparate financial systems, we're starting to get to a place where we can get a deeper and better understanding of the entire system and the cost and cost pressures associated with all of our operations. We look forward to the implementation of a single financial system in the next couple of years. We knew that each health and social services authority were experiencing annual deficits when we assumed oversight in August of 2016. When we consolidated, we discovered our financial reality was a $76 million accumulated deficit at the end of the fiscal 16-17. Our financial reality is not rosy. We have inherited large financial deficits with continued pressures and increasing costs. Our territory has the highest per capita private and public cost at $17,150 per resident of health and social services costs in Canada. This data comes from the Canadian Institute for Health Information. Our highest cost drivers are really twofold. They're around compensation and benefits and our medical travel. As CEO, I take this deficit situation extremely seriously. Dealing with this financial reality is one of our major challenges moving forward. To that end, we are continuing to build our partnerships with the Department of Health and Social Services and the Department of Finance to put our collective knowledge and skills together to find solutions that will work to ensure that we can continue to deliver quality care and services to our residents. There is a bright side to this. With the creation of the NTHC, I truly believe that we have never been better positioned to understand the cost drivers in our system and make changes to ensure that we address issues with variability in services and make consistent and equitable access for NWT residents in the future. On slide 11, as we examine opportunities to innovate, or how we can do things differently, or how we can introduce innovations we can benefit from across our system, we are also finding areas that need improvement. With the establishment of our territorial operations team and in collaboration with regional operations, we are taking an approach that includes proactive program reviews as a major part of our ongoing efforts to take deep dives on specific part of our operations. We are finding that these reviews sometimes lead us to discovering issues that for various reasons were not rectified in the past. When we discover these issues, they are rarely seen as good news stories. The Stanton chemotherapy suspension is a perfect example of this. Following a review of our chemotherapy program, we knew that we had work to do to improve training for practitioners, improve policies and procedures, and make improvements related to equipment. We suspended the program to ensure that all of our changes and improvements to our chemotherapy program at Stanton will result in exemplary service delivery once we restart the services here again at Stanton. That's what I want. That's what our territorial teams want. That's what our regional teams want for our patients and clients in the Northwest Territories. We expect, as we continue to examine how we deliver care and services, there will be other instances where we will make similar program decisions. I am unapologetic about making future program change decisions because it's the right thing to do. It's about quality care and service delivery for our patients and our clients. We know we can always improve the way we provide care and services, and we are committed to doing that. While the headlines may read bad, the impact on patient care and improvement in our system is nothing but positive. When we become aware of an issue, we want to take action to address it. So these are rarely seen as good news stories. But we've initiated a practice in the NTHC where issues and program decisions like this bring our team together to respond to incidents. This approach is allowing us to make decisions that protect patient safety, that examine the issues on a deep level so that we can understand them and make quick decisions for corrective action, so that we can develop policies and practices that can be used to improve other parts within our system, so that we can communicate clearly with those impacted through a process that prioritizes patient communication, notification to key stakeholders like the Department of Health and Social Services, and to you as MLAs, and then to proactively, publicly disclose these issues in an honest and transparent way. Ultimately, this work can raise concerns in public discourse, but it is necessary to ensure we are providing the best possible care and services to our residents. We believe that one of the signs of a high-performing health system is being able to proactively find and quality issues and address them in a transparent and honest way that improves the way that we take care of people. Our recent actions are demonstrating this behavior, and we will continue to find and fix quality issues as we go forward. On slide 12, from an innovation perspective, throughout our system, we are examining our operations and our practices with a focus on quality improvement. And this includes examining how things are not only done in the context of national and international best practice, but are also looking at strong local best practices that can inform how we can improve care and services. When Accreditation Canada came to the Northwest Territories in September of last year to do a bridging survey, they were really pleased to see a number of best practices and strengths already within our system. So we are taking their instruction to take a strengths-based approach for the benefit of our entire authority. Our previous system didn't allow us to do that. We had 5 health and social services authorities of the 8 who had participated in the Accreditation Canada process, but each participated in a siloed way and didn't share policies, procedures, and best practices. Now with the NTHC, we have the ability to share policies and practices within the NTHC, and also including Hay River and Clicon. This learning within the system is a necessary step in understanding what works best within our northern context, and then taking those lessons and standardizing our care and services. We are also working hard to ensure that we have a system that is quantifiable through the measurement of valid data points. Part of this work is encompassed in the implementation of a territorial-wide electronic medical record, or EMR, which when complete will be the first of its kind in Canada. This means we will be the only jurisdiction in Canada with one electronic medical record across the entire jurisdiction. This is an enviable position to be in because the EMR data presents a massive opportunity to take that data and drive future quality improvement decisions that are based on real evidence. We have initiated, as you probably heard in the last week, the NT Choosing Wisely campaign. This campaign helps clinicians and patients engage in conversations about unnecessary tests and treatments and make smart and effective choices to ensure high-quality care. In the Northwest Territories, we did an education campaign on inappropriate prescribing of proton pump inhibitors, or PPIs, as part of our Choosing Widely. So PPIs are a group of medications that reduce stomach acid, and over time, long-term use can actually lead to many adverse events. And so we want to see a reduction in the proton pump inhibitor prescribing rates. With education, in 2017, the appropriateness of PPI prescriptions improved by 20% from 2016. That's good news for our patients. Our next priorities are antibiotics wisely. So looking at reducing unnecessary antibiotic prescriptions. Diagnostic imaging specifically related to low back pain. In 2016, 31% of imaging for low back pain in the Northwest Territories was unnecessary and unexplained. We are introducing a new requisition to ensure appropriateness of imaging, and we will track that impact. In Alberta, they did the same thing, and they actually saw a 20% reduction in inappropriate low back imaging. We are also looking at unnecessary and duplicated lab testing for our patients. Clinical indicators are also being tracked in the emergency departments for the purposes of improvement and are being fed back to clinicians on emergency department lengths of stay and admission rates. We are doing reviews of medevacs. We are looking at trends regarding our medevac data to determine trends for unnecessary or inappropriate transports. We want to begin to make evidence-based program decisions, and we are beginning to do that. These opportunities have all been made possible through being one system. We are taking this work very seriously and have been providing regular opportunities for leaders across our system to get together and build capacity to ensure that we have the right people in the right places with the right skills to make an impact as we make system change. Changing the way we operate, the way staff work, and the way people behave is difficult. As we all know, culture shift is challenging, and it takes time. We would say that a change to a practice or a process can take up to a year to embed in the system. We want to know staff needs and understand the frontline perspective. To this end, we've implemented a system-wide integrated staff feedback program that allows us to receive and to answer questions from across our operations. As we develop standardized policies and practices, we are working towards system-wide accreditation, which will provide an outside lens to ensure our system is operating according to standards and that our improvement efforts are working. At this time, we are working to ensure that the people within our system have the skills and the data to support sustainable change so that we can all benefit. On slide 13, the strategic vision for our system includes enhancing patient and client experience and ensuring our programs and services are culturally sensitive and responsive to community wellness. We know that in order to achieve these goals, we need to build stronger relationships with the people we serve to better understand their needs. Part of this work is ensuring that people have an avenue to address issues they have within the system. Some of this work is being undertaken as we develop a comprehensive client-patient feedback and complaints process. We often talk about a vision of a system where patient, client, and family are a bigger part of the process, where people are accountable for their health and wellness and are empowered to participate in the care and services that they receive. An important part of reaching this vision is ensuring people have avenues to raise and address concerns, complaints, and compliments, so that we can improve our care and services, because we know that we can always do better. Currently, this often happens through the ministerial bring forward process, with many complaints being directed through MLAs. We hope that by establishing a transparent and accountable process for people to raise, escalate, and consistently seek resolution to complaints or issues they raise, that we will be able to be more responsive to those that we care for and serve. So please expect to hear more about this work over the coming year. We also know that we have much work to do in the area of providing culturally safe care and services. And over the past year, we have participated in the work being undertaken by the Department of Health and Social Services that aim to build a culturally respectful health and social services system. To advance this work, we have also begun testing out some practical ways to implement cultural practices and supports within our system. One example of this would be the Elder in Residence program that is ongoing at Stanton Hospital. We aim to build trust for those we care for. So our message about personal responsibilities and taking care of your own health and wellness are heard. On slide 14, within the new authority, we'll want to continuously seek ways to find the most efficient and effective ways to provide seamless pathways for our patients and clients. So we're wanting to look at ways that we can move patients, but also move their information. So with the establishment of the authority, we've made the process for those who need to leave their home community for care and services more consistent and easier. This includes the ability to move patients' information. We would much rather move patients' information and provide care closer to home than having patients have to move or use a medical travel system to transport out of their community. And oftentimes that isn't possible and they will need to travel out. But what a great opportunity it might be to look at moving information instead of people. This has many benefits, from reducing impact on people by not having them leave their communities and potentially speeding the delivery of care and services and reducing cost. This work has been talked about for a long time, and we've made great advances through previous authorities and our partners to build a basis to make this possible, such as the work on the single EMR, which will make this so much easier. So slide 15 talks about moving forward, and slide 16 talks about 2018, 19, and beyond. So going forward, our focus is going to be on 3 key areas: continuous quality improvement, fiscal sustainability, and strategic direction. Under CQI, continuous quality improvement will always be an important area and a theme that we are constantly focused on as we make system change. As I have highlighted, much of our work is focused on building a base upon which future initiatives can have real impacts on both quality of care and experience, as well as system sustainability. Fiscal sustainability. Regarding that, we are well aware of the challenges that we face. I expect that we will be able to make some positive contributions to fiscal sustainability through quality improvement initiatives that find efficiencies in our system while also leading to better care and outcomes. We also have new opportunities as an amalgamated authority to look at ways to save on shared contracting and other services. So as an example, in the past, each authority may have negotiated separate contracts. As an example, maintenance of X-ray equipment or purchasing of software were negotiated separately. So we would have the opportunity now to do one contract. With our one system approach, we have opportunities to negotiate one contract, which will lead to benefits of economies of scale. As a system, we need to ensure that our strategy aligns with government and that everyone in our system understands the bigger picture strategy for improvement. Permeating this understanding and these new attitudes in our system is a challenge, but we will continue this work because it is a key driver of successful and sustainable change. Over our first 18 months, we have been in a building mode, and our main focus has been on core stability. As an authority, we will continue to deliver good care and services to residents and communities across the territory. However, we know we can do better, and system transformation is empowering us to make changes to do better. We will continue to focus on quality improvement as our key driver to decisions going forward. This will take time. However, we know that we are building a team that are focused on delivering high-quality care and services for the people we serve. Our final slide, slide 17, illustrates some of our achievements so far. We're continuing to face massive change, and through this, we have been able to continue delivering quality care and services to residents every day. So we're continuing to create core stability. Our organizational design, we've staffed leadership positions throughout the system, most of these within the system. Our design is near complete, and implementation is happening now. This is a major point of progress in building our ability to support further change. Corporate and practitioner bylaws. We have collaboratively developed and implemented our leadership council's corporate bylaws and our medical and professional staff bylaws. Our medical and professional staff bylaws are a key step in realizing the goal of creating a territorial medical staff. Partnerships. We've maintained and built partnerships within our system with Hay River Health and Social Services Authority and with the Cleachon Community Services Agency. We continue our strong partnerships with the Department of Health and Social Services and Finance to put the best people possible on our finance issues. Across our operations, we have enhanced regional links. New committees and structures have been created to advance change and build collaboration. An example of this will be our Territorial Practitioner Executive Committee, who are now well underway in improving and enhancing care that practitioners provide. Building and enhancing partnerships with outside organizations like Alberta Health Services and Cancer Control Alberta. Governance capacity building. We've supported the onboarding of our first Leadership Council and cohort of Regional Wellness Councils. While we have held a number of orientation training and capacity building events, we know we have much more work to do and are excited to continue on with that orientation and training. Transparency and accountability. We've been regularly communicating with patients and stakeholders and public about issues and shortfalls in care and services. We've enhanced media profile and more direct, regular public communication by working with those in the system. We've established our authority presence through branding and on our web. We've worked together to bring together 6 separate budgets. We've collaborated with the Auditor General of Canada and received an unqualified opinion on our first financial audit. We've held our first annual general meeting and produced our first annual report. We've transitioned the information and health technologies team that provides the support to our electronic medical record. And we've got EMR coverage for 90% of the Northwest Territories residents. Advanced EMR implementation across the territory, when complete, as I mentioned before, will be the first territory in Canada to achieve a single EMR. And Stanton Renewal, we've supported one of the largest and most complex projects in the GNWT history while also experiencing massive change throughout all operations. I would like to thank you, Mr. Chair, for the opportunity to provide this update, and I would welcome the opportunity to return to provide future updates as we continue to build our strong authority.
Thank you, Ms. Collins. Questions? Mr. Beaulieu.
Yeah, I'd like to start off with a question of clarification. You had indicated you have 2 cost drivers. One was medical travel. I just wanted to know what the other one was.
Okay, thank you, Mr. Beaulieu. Mr. Abernethy.
Thank you, Mr. Chair. Mr. Chair, that comment was in respect to the fact that we have the highest per person cost in the country of 17,000 and some change. We know that some of the cost drivers that are different for us compared to some of the other jurisdictions are things like medical travel. But we also know that one of the other cost drivers we have is salary costs, and that includes base salary, employer share, overtime, all of those types of things. We have some great compensation packages here in the Northwest Territories.
Thank you, Minister Abernethy. Mr. Beaulieu.
Thank you, Mr. Chairman. Mr. Chairman, one of the things that what was not mentioned here was the possibility of having all our doctors living in the Northwest Territories as opposed to using locums. I'd like to know what the system feels is if the system feels that this would be a positive thing for the bottom line. You're talking about $76 million in deficits, accumulated deficits from one authority to the next. When it's rolled up into one big authority, that was the cost. I'm wondering if there's a role in the development of hiring all doctors locally, and if the doctors themselves would play a development role in transforming the system. Thank you.
Thank you, Mr. Bolio. Minister Abernethy.
Thank you, Mr. Chair, and I will go to Ms. Cullen for this, but short answer is yes, we get that there's significant value in having all of our practitioners live in the Northwest Territories, not just our physicians, but I think important work has been done to try and, create a territorial pool and to hire as many people as we can, recognizing there will likely always be a need for some locum to cover things like holidays and sick times and maternity leaves, but I will go to Ms. Cullen, who could talk a little bit more about the value in doing this work.
Thank you, Minister Abernethy. Ms. Cullen.
Thank you, Mr. Chair. It's an excellent question. Our vision is down the road to absolutely have doctors living and providing services for residents in the Northwest Territories. We know that our model of care and services now, from a physician perspective, has many locums coming up to provide general practitioner, family physician services and specialist services. And so our vision would be to ensure that we can look to a time where we would have physicians living and providing services in the Northwest Territories. And we may not have the opportunity to have physicians living in smaller communities, but in the major centers, in Inuvik, in Hay River, in Yellowknife, in Fort Smith, where we could actually have a permanent Northwest Territories physicians living in those communities and being adopted in those smaller communities and providing consistent care that is culturally appropriate. And so that is absolutely our vision going forward. We know that locum physician costs are probably 1.5 times what a GNWT physician costs are. And so we're trying to, over time, to actually look at reducing those locums outside of that sort of backstop for annual leave and that kind of thing. The other area that we're really looking at is we have a number of specialists that are providing services to the residents of the Northwest Territories, specialist services that we wouldn't have necessarily because they're highly specialized, neurology, cardiology, rheumatology, that come up and provide services here. And so we have to also look at our model for specialist services as well. But yes, again, a bit of a longer answer to the question.
Thank you, Ms. Cullen. Minister Abernethy.
Thank you, Mr. Chair. And the Department and the Authority are working closely on this. For instance, the Department has taken a lead on some negotiations and discussions with the U of A about doing some more residency placements up here. That's going to obviously benefit the work that the Authority is doing. So we're working together on those types of things. And we also, it'd be better for us to have the physicians in the Northwest Territories going out to our communities on rotation. They go out every a couple times a year from Yellowknife, rather than from the south. So we're trying to find ways to make that happen. I think that's work that the member started when he was the minister, and we're continuing to build on that work.
Thank you, Minister Abernethy. Just to follow up on that question, and I'll turn it back to Mr. Bolio. It's a vision. What are you guys doing to recruit young doctors and getting them up north? Because, I mean, it's great to get older doctors and that, but the potential of young doctors out there that, are looking for that adventure, has the department or the authority been looking at doing that and actually following an implementation plan on that? Minister Abernethy.
So that's exactly what I was talking about, Mr. Chair. I mean, if you look at a relationship with an organization like U of A where we can get some residential placements up here, we can get those people up here. Hopefully, they'll fall in love with the territories as much as your parents fell in love with the territories, my parents fell in love with the territories, and hopefully they'll stay. And we have actually seen some positive results on that. Prior to coming together as a single authority, Beaufort Delta had a relationship with, I think it was UBC, where they were bringing residents up. Inuvik was one of these areas where we had a really hard time getting permanent physicians. In fact, for years, we didn't have any. As a result of that work, we actually had a group of students who came up on residencies. They liked it, and they worked together, and we ended up getting a whole bunch of them from UBC who are, classmates, cohorts, friends who have come up. So we know there's opportunity here. We're pursuing those opportunities. There is some resident placement still happening. We're trying to have a more formalized approach with U of A. They're interested. We're interested. We're just putting together the details so we could start to see it happen.
Thank you, Mr. Abernethy. Mr. Willie, do you have any follow-up?
Yeah. Thank you, Mr. Chairman. Mr. Chairman, I realize that Hay River Health and Social Services has essentially a different public service. However, I had envisioned that it would fit into the system better, I would say, than what has occurred. I still have individuals that will leave Fort Resolution on their own and get a medical appointment in Hay River, see a doctor in Hay River, and that's, but it has its separate, and because they were a part of YK Health and Social Services, people continue to get up at 4 a.m. to catch a 7 o'clock flight out of Hay River, come here, go for their appointment, spend their day here, get back on a flight, and then cab it home. So Hay River seems to be the ideal place if there's the doctors there to where the people from Fort Res could make the appointment. I was assuming when the new health center in Hay River was built that it would play a bigger role for the area, because I know that even though social services from the reserve responds to or is part of Fort Simpson, that I think the people from the reserve just go to Hay River for their medical needs. Even though they're a part of DETRO. So I'm wondering if Hay River is going to actually play a larger role for the surrounding communities as far as health services goes. Thank you.
Thank you, Mr. Bolio. Minister Abernethy.
So, thank you, Mr. Chair, and thanks to the member for that question. When the new hospital was built in Hay River, it wasn't actually an expansion of services. No new or additional services were added. It was a provision of the existing services. For years, we've had problem getting permanent physicians. We do have a little bit more stability there than we've had in the past, and we're hoping to continue to do that. The authority is not part of the single authority, but we act and work as if we are through memorandums of understanding and agreements. So residents from Fort Res and other communities can go to Hay River, absolutely. We still have some challenges around referring to Hay River for specific things that are delivered in Yellowknife, and that's work that we need to continue to do to make the patient experience less complicated. Why fly somebody to Yellowknife if they can get the service in Hay River? We know that we need to do more work there, but we also need to continue to move forward with bringing Hay River into the public service, which will help some of those things. That's going to still be a while. I mean, it's a significant amount of work. We're still trying to quantify the actual costs, and then we have to bring it back to the Assembly for further discussion. But that's part of our mandate item, and we're still working on that. But we agree with you that, we haven't fully nailed it. There's room for improvements there, but we hear you, and we're trying to find ways to make that better. Did you want to add anything?
No,
Thank you, Minister Abernethy. Ms. Collins.
That's right. Thank you, Mr. Chair. We work very closely with Hay River and Cleachon Community Services Agency, and so we can be stronger together. And so while there is a different, they're under a different union agreement, and they have a separate operating entity, we're really looking forward to a time when we can actually bring them on. And so we're behaving as though we're working together despite these differences. So really involving Hay River in our discussions.
Thank you, Ms. Collins. Mr. Antoine.
Yes, thank you, Mr. Chair. On your question there, the honorable member, Tom Beaulieu, is that the, as a board, and we know the situation in Hay River, is that the reality is that people from Fort Resolution, as well as from Fort Providence and Kankisa, do go to Hay River. You know, once this new building was building, it's a beautiful building, that provides excellent services. And why not use those services? But we're still affiliated like with Tunede and also with the DHO, you know, but it's something that we need to work on, I think, you know, at some point. You know, I think we need your help as MLAs. You know, you talk to people and we gotta work together on figuring this out. There's an affiliation with the DHO with Providence and Kankisa. And as well as Fort Resolution is with Yellowknife, so Hay River is there. The reality at some point is that we have to make a decision on what's for providing the best care and service for our people. You know, so if somebody, like, you know, on a personal level, if, you know, one of the members of my family's not well, I'll take them wherever I'm going to take them. You know, I think that's people thinking like that, you know. So at some point, we need to come to work this. You know, it's not clear decision here. It's that, it's something that's evolving and establishing itself.
Thank you, Mr. Anton. Ms. Green.
Thank you, Mr. Chair. Thank you for your presentation. What I hear and what I have experienced is that there is significant effort to have patients manage their demands of the health system. But I'm not hearing an equivalent focus on managing the cost pressures from clinicians. And so is that something that is also happening but not highlighted here, or how is that going?
Thank you, Ms. Green. Minister Abernethy.
Thank you. And I'm going to go to Ms. Cullen on this one, but things are happening, Mr. Chair. For instance, the Choosing Wisely is a big step to getting practitioners, whether it's community health nurses in communities, whether it's doctors, physicians, specialists in Yellowknife, to think about the things they're ordering, the tests they're ordering. As a system, and the chair and I were talking about this before, is, I mean, we've got some really high overtime stuff out there, and we are looking to make sure that our systems are logical and streamlined to make sure that, you know, the use of overtime makes sense as opposed to, you know, it's needed as opposed to expected, those types of things. So, but Choosing Wisely is, I think, one of the examples of the things we're really doing to try to control and streamline our spending. But I would go to Ms. Cullen for some addition.
Thank you, Minister Abernethy. Ms. Cullen.
Thank you, Mr. Chair. Absolutely. The Choosing Wisely campaign actually is an excellent example where clinicians and patients actually engage on what is the best avenue for care and treatment for them. And so looking at things like antibiotics wisely. Do you actually need the antibiotics? The diagnostic imaging, looking at trying to reduce imaging of low back pain to prevent unnecessary imaging. Lab testing. As an example, we know that bringing locums up to the Northwest Territories to provide services, we see a huge spike in orders for lab testing and other medications that our NWT physicians would maybe not offer. And so the goal would be to have a more organized team of practitioners, including nurse practitioners, midwives, and dentists, providing those services that are consistent and engaging with dialogue with patients and clients to ensure that we're doing the right thing for the right reason.
Thank you, Ms. Collins. Ms. Green.
Thank you for your response. During the presentation, there are a number of mentions of unnecessary and/or inappropriate testing. Do you have a definition for those terms, please?
Thank you, Ms. Green. Ms. Collins.
Thank you, Mr. Chair. It is a clinical, it's based on clinical decision-making in terms of unnecessary, and so I can't formally answer the question, but it is a technical, there are technical reasons why it would be deemed to be unnecessary.
Thank you, Ms. Collins. Ms. Green.
Thank you. Is that also true for the term inappropriate?
Thank you, Ms. Green. Ms. Collins?
Yes, Mr. Chair.
Okay, Mr. Natalie?
Yeah, thank you, Mr. Chair. Yeah, I think Mr. Antoine maybe have referenced the Association of the Hay River Reserve and whether it's part of the Hay River Health and Social Services Authority or else part of the Decho Wellness Council. So I'm just trying to get an understanding whether that decision is really left up to the community of Haudenosaunee First Nations, and whether maybe the department plays a role in recommending that they be part of the Decho rather than the Hay River Health Authority. Thank you.
Thank you, Mr. Natalie. Minister Abernethy?
Thank you, Mr. Chair. So this comes back a bit of a way, you know, around the time we were doing the legislation and establishing the first regional wellness councils. We did approach Katladeche and indicate or seek, you know, their advice and their opinion on where they would like to be seated as far as having seats on regional wellness councils. And they actually do have a seat on the Regional Wellness Council for Hay River, recognizing that residents of Katladeche can go anywhere in the Northwest Territories, in fact, anywhere in Canada they want for services, but they're receiving most of their services in Hay River, at least at the front line. So they actually have a seat on the Regional Wellness Council in Hay River.
Thank you, Minister Abernethy. Mr. Natalie?
Thank you, Mr. Chair. Yeah, I guess the second part of that question I wanted to ask is that ultimately, I think the vision of the department is to have a one system that'll serve everybody in the NWT. There had been some discussions of like the Clean Services Agency and then the Hay River Health Authority and how they could be maybe merged into the larger body. Is that still perhaps the vision of the department? Thank you.
Thank you, Mr. Natalie. Minister Abernethy?
Thank you, Mr. Chair. Mr. Chair, we want an integrated, collaborative, single system. Yes, absolutely. But there are some realities that we have to accept. Right now, Hay River is technically outside of the authority. We work as a single authority with them by way of agreements. We still want to bring those into the public service. The Tlicho is a little different as a result of their self-government and land claims agreements and the fact that they're a government with unique structures. Their structure is the TCSA, which continues to exist and will continue to exist. Now, when it comes to healthcare, we have a relationship with them by way of a memorandum of understanding and other agreements that they will work with us as part of a single system, even though technically their board is outside. I imagine that should, or when, hopefully soon, we do reach resolution with different indigenous governments and self-government and land claim agreements are established, that may change our structure a little bit where we have to duplicate a TCSA type arrangement. That's fine, but we will do that through memorandums of understanding and agreements to make sure that we are behaving as a single entity for the delivery of health services, unless there are components that governments choose to draw down, and based on their agreements, they do have the right to do that. To date, nobody has drawn down any of those authorities.
Thank you, Minister Abernethy. Mr. Natalie? Okay. Mr. Riley?
Thanks, Mr. Chair. So on slide 10, it's mentioned that there's a $76 million accumulated deficit. Can someone just tell me a little bit about how that was calculated and where we would find details of that? Is it in the public accounts, or I tried to look up the annual report, 2016-17 annual report. It's not on the website, but some details on what this consists of and where it's reported. Thanks, Mr. Chair.
Thank you, Mr. Riley. Minister Abernethy?
Thank you, Mr. Chair, and this is certainly an area that has been raised as a concern both by the board, by the FMB, by others. It's been growing since 2007. In 2007, I believe there was about a $27 million deficit or $25 million deficit, accumulated deficit amongst all the authorities. At that time, it was waived, and since 2007, it has continued to grow a couple $1 million a year. And it's still growing. As a single authority, our goal here is to try to better understand that growth, make improvements to control spending, and get it under control. As far as the detail, and the year-to-year amount, I will commit to getting some additional information for committee on the deficit and provide that to you at a later date. I don't have the specific details on the deficit at our fingertips today.
Thank you,
I do know that it's still growing.
Thank you, Minister Abernethy. Mr. O'Reilly.
Thanks, yeah, and I think the minister started to discuss this. What sort of lessons can we learn from that? Obviously, transformation is part of the response, but what areas is the deficit growing in? What can we do about those areas? What are we going to learn from that, and how are we going to respond? And I don't know whether that's information he's going to provide later, or is there even some high-level things he can help us with today? Thanks, Mr. Chair.
Thank you, Mr. O'Reilly. Minister Abernethy.
So, Mr. Chair, there is a lot of work that still needs to be done here, and the board has been getting briefed regularly and looking and reviewing these areas and providing advice to the authority. I'll let the chair talk a little bit about that. But having said that, in the budget that's in front of us today, we have put in some fourth growth in areas that are driving costs for the system, which will help control some of the pressure points on our deficit, but not all of them. We have put money in for southern placements that we have, and a few other things. So there are some things that we're doing already that will also reduce the number of subs we ask for in the future. But the pressures continue to be there. We really need to continue to dig into the system to find our efficiencies and fix the system so that we are getting maximum benefit for every dollar that we spend. It's going to be a lot of work, but we're committed to getting it done. Jim, did you want to add
Thank
anything?
you, Minister Abernethy. Mr. Antoine.
Okay, thank you, Mr. Chair. Just to answer the question of MLA O'Reilly, is that this accumulated deficit, we acquired it, but over the years, each authority was accumulating their own deficit, and it's been adding up. And we have a financial team with the board now for the last 18 months, and we've been working with the financial managers of each authority and the COOs, looking at all and working towards this budget. And we're finding out some specific areas where this deficit is occurring. And the minister mentioned some areas, and medical travel, the compensation to the doctors and the locums and so forth, and overtime, so we've identified some of the areas, and we need to make some decisions on that, on what we're gonna do about it. And I think it's doable, but with a single authority, it's easier to do it. The authorities in the past have made some legacy decisions, and it just perpetuates itself. And we need to look at it and find out what it is. And then once we have a good handle on it, then we could make some decisions. As for the specifics of it, if you wanna, the CEO, Sue Cullen here, is very up to date with the specifics of where some of these deficits may be happening. So if she could comment on that, Mr. Chair.
Thank you, Mr.
Thank you.
Antoine. Ms. Collins.
Thank you, Mr. Chair. When we look at our expenditures, just about 65% of our expenditures are related to compensation and benefits. And so those costs really drive our deficit. We are seeing, as our chair has mentioned, we are seeing costs associated with locum nurses, physicians, social workers. We're seeing costs in overtime, sick time, callback, mandatory leaves. There are a number of varied staffing models across the regions that we haven't really got our arms around yet, and so we have inherited legacy systems and legacy decisions that have been made. We also have a number of unfunded positions that are in place in the system. So we have positions that are providing care and services, but there isn't requisite revenue for those positions. So it's really, compensation and benefits is a big cost driver, and then looking at medical travel. We're seeing significant increases in medical travel, particularly down to Alberta Health Services. And so our physicians are really anxious to figure out how can we actually start to change the trajectory of sending people south, and what can we do to improve and enhance the services that we provide here in the Northwest Territories. So those are really two of the big drivers. Another driver is, in the coming budget, is that as we move to a new hospital, we're going to ensure that our staff are trained and oriented to our new design, the new equipment that's in place, and so that will actually also have some cost implications as well, so.
Thank you, Ms. Collins. Minister Abernethy.
And as we all know in this room, we also have some new cost pressures coming at us. We're moving forward with 258 long-term care beds in this territories in the next 9 years, which is going to create, possibly as many as 200 new jobs in this territories in communities like Inuvik, Hay River, Fort Simpson, and Yellowknife. And those have to be paid for out of somewhere. So there's lots of cost pressures coming our way, and we need to make sure that we're getting maximum benefit for every dollar that we spend.
Okay, thank you, Minister Abernethy. I do have one question into this, and I'll turn back to Mr. O'Reilly. So with this debt, is this something that belongs to the GNWT and it's accounted for in our debt, or is it something that the NWT Health and Social Service Authority is owning on that? So right now, we're talking $76 million. Is it part of our overall debt, or is it something that's off to the side and it belongs to NWT Health and Social Services Authority? Minister Abernethy?
Thank you, Mr. Chair. Mr. Chair, ultimately, we're all GNWT, and the debt is of the GNWT. It is a debt borne by the territorial authorities, and now the single authority, I guess the three authorities. But ultimately, it's all GNWT.
So, thank you, Minister Abernethy. So it is counted into our debt process, and we're asking.
It doesn't show up as part of our short-term debt, though, right?
Minister Abernethy?
We believe so, but let me talk to the Minister of Finance to get the most appropriate answer to that.
Okay, Mr. O'Reilly, your last question?
Yeah, thanks. Let's talk about something a little bit more positive, the Arctic Indigenous Wellness Project. And the Arctic Inspiration Prize. I think there was some rocky stuff that happened there for a while, but things seem to be headed in the right direction. Tell us a little bit more about how you intend to be working with the project, and how that's going to be incorporated into the new hospital as well as throughout our healthcare system. Thanks, Mr. Chair.
Thank you, Mr. O'Reilly. Minister Abernethy.
I'll talk a little bit about this one, and then I'd like to go to the chair, who I know has been talking to the AWG quite a bit. As we move forward with the Stanton campus, we've always said, or at least I've always said, that we wanted to make room on that campus somewhere for a wellness-type center focusing on providing traditional healing practice and wellness activities. The Arctic Indigenous Wellness Foundation did become a reality, and at first it looked like they were looking for some property off of the Stanton campus in Yellowknife. I don't believe they were able to find it. I reconfirmed our commitment to utilizing our site. We have identified a location on the site, and they're doing a temporary sort of camp on that site right now, and they're just working through some of the details. We've been very supportive of them. We see a real opportunity to work, side by side, recognizing that residents may want to be able to use both aspects, traditional healing as well as more Western practices, and we see real value in incorporating traditional wellness into our modeling. And we're excited to be partners with them and to be working with them on this. I nominated them for the Arctic Inspiration Prize, and we're very excited that they won the $1 million prize and that they're continuing to move forward. And, you know, it's still early days. I still think they're trying to put together some of their ideas now that they've got the prize. It's certainly going to open them up to more possibilities. I've made a commitment to working with them to see if there's any opportunity to obtain some federal funds to help with the move forward of this initiative. I'm excited by the opportunities. I think they're excited by the opportunities, and I think, you know, together we can do something that will benefit the people. And I know I know that the chair's had a lot of conversations with them, so I'd love to hear from him as well.
Okay, thank you, Minister Abernethy. Just because of the time, we only got a couple minutes left, because there's another committee meeting here at 12, and we do have to do a little bit of wrap-up, and we're hoping that you guys can come back again, because I've seen we're having some pretty good discussion here. But at this point in time, I'll turn the floor over to Mr. Antoine.
Thank you, Mr. Chair. Just to briefly add on to what the minister is saying about the Arctic Indigenous Wellness Foundation, is that he covered most of it already, because it's in their early days after they got their $1 million, so they're kind of flush right now, and they're reorganizing, and they want to try to bring people together now to really seriously start getting things done. But they're setting up a camp over by the hospital there, and they're moving ahead with it. That's all I could add to that.
Thank you, Mr.
Just in closing, I'd like to also offer with it to your standing committee to work with the with our board, because we're new, and we need to work together, because we're trying to provide the best care, the best service for our people. We try to focus on the patient rather than on the system, you know, and any help that you could offer us, I appreciate that.
Thank you, Mr. Antoine. Minister Abernethy.
Thank you very much, and I have to go as well. I've got a meeting downstairs at noon, but thank you so much. We want to come back. We want to keep talking. I think there's lots of good things coming. There's challenges. We're going to have to make tough decisions together in order to get this right. The board is committed. There's lots of work that we have to do to help strengthen the board too. We want to make sure that they got good training, that they're getting the resources they need. And we look forward to meeting and working together on this, and we're happy to meet whenever, assuming we can all get together at the same time.
Okay, thank you, Minister Abernethy. Ms. Green does have one short, quick one, and then,
Yeah, I just wanted to bring to your attention, when I lived in Labrador 25 years ago, Memorial University was sending medical students up to Labrador to be residents, to interest them in life in the north. Although Labrador is south of 60, it is in many ways more northern and more remote than Yellowknife. And so I don't know if that program still exists, but it might provide the kind of model you're looking for and how to recruit people to come and stay.
thank you, Mr. Green. Minister Abernethy?
That was one of the exact models that we discussed when we were meeting with U of A, the deans of the medical program. We're still early days on that, but they're not talking about just doing residencies. There's some desire for them to do even just visitations to some of our smaller communities. So there's a lot of interesting things happening here that could be really, really good. We're working on it, and that exact model was what we discussed when we were sitting around the table. So
Okay,
thank you so much.
Thank you, Minister Abernethy, Mr. Antoine, Ms. Collins, Mr. Cooper. Thank you very much, and we'll get back to you guys again. And so we'll just do a brief wrap-up.
Thank you, and we'll